I'm here to share with you about screening for breast cancer in women. Breast cancer is the leading cause of death for Singaporean women. Incidence has increased from about 20 per 100,000 in the late 1960s to what it is now, about 59 per 100,000. The growth has been steady at about 4% per annum, and our Singaporean women have a 1 in 16 lifetime risk for developing breast cancer. In Singapore, the increased incidence is confined to the group of women above 40 years of age, and the peak incidence is at about 55 to 60 years old. How do we compare with the rest of the world? Our incidences are higher than most of the other Asian countries. This is the incidence in Singapore, but we are lower than countries like Australia or USA. The underlying premise for screening with mammogram is that it allows for detection of cancers before they become palpable. Okay, and we all know that detection of early stage disease confers better prognosis and better outcome when treated. Okay, to date, there has been at least 8 randomized controlled trials on population-based mammography. There is some variation in the outcome with regard to mortality reduction, but on the balance, we are looking at about 24% reduction in mortality in the group that is screened compared to the group that is not screened. Suspicious findings on mammogram that we look for are mass and distortion or clustered microcalcifications, and these require further assessment. Cancers are generally more easily detected when the background breast tissue is fatty, like the case on your left. Okay, but then when the breast tissue is very dense, it can be quite tricky. You find that this is the situation of dense breasts. We tend to see them in the younger women, and that is why we have this false negative rate from mammography of about 15%. Generally, the false negative rate would be higher for the younger women because of the dense breast. Breast cancer screening can be sporadic. That means the women choose to have mammography at her own discretion. Or it can be population-based, where women are invited to have mammography at certain predetermined intervals. For instance, in our local breast screen program in Singapore. So for about 10,000 women screened, usually about 10% recall for additional mammogram and ultrasound. Okay, and of these, about a third would have suspicious findings that warrant a needle biopsy, and we will detect a few cancers. Okay, so we have to realize that although there are significant benefits that can be realized from screening mammography, there are also harms that we have to be aware of, and a lot of these relate to anxiety. There is high level of anxiety during the assessment process, and women who were recalled for assessment tend to have a lot of anxiety even years later. There's also the problem of missed cancers. There's also the radiation-induced cancer. I've put this in bracket because I would say that the risk is negligible with the current state-of-the-art equipment. And there's also the risk of overdiagnosis, which again I've put in bracket because it can be quite difficult to explain to the women. Overdiagnosis refers to cancers that are detected through screening that are so indolent that it would not have been detected in the lifetime of the women if we had not done screening. Okay, but then it is reassuring to know that between 2 to 2.5 lives are saved for every 1 case that is overdiagnosed. Ultrasound, when do we use ultrasound? It is a useful modality for the assessment of a mammographic abnormality, but there is no scientific evidence for use of ultrasound alone for screening. I would say routine use of ultrasound is likely to increase the number of false positive cases, and this would lead to increased anxiety, more biopsies. Okay. Usually in younger women, many of these ultrasound detected nodules are going to be benign, and if they are left alone, they would involute with time. So as a guideline, our group have decided that breast ultrasound should not be used for routine breast screening. It has a definite role in problem-solving a mammographic abnormality. We go on to the key recommendations. All normal risk asymptomatic women 50 to 69 years of age should be screened with mammography only once every 2 years. By normal risk, we mean women without genetic risk factors or previous breast conditions. Ultrasound and clinical breast examination are not routinely required. What do we do for the younger women 40 40 to 69. After looking at international guidelines, the fact that actually quite a large proportion of our breast cancer cases are in the younger women. Women between 40 to 49. There is about 40, they comprise 40% of our total breast cancer cases. Because of the high incidence in our local population, we have advocated screening also for this group. Okay, but then it is on an informed choice strategy. Okay, and by informed choice we mean that these women should be told of the benefits of mammography, that is the reduced mortality, but they should also be told of the limitations. Because of the denser breast in younger women, it can be hard to detect cancers. They are also more likely to be recalled for further assessment. Okay, so they have to be brave if they were to come for screening. Okay, and also if screening is to be performed in this group, it is to be done annually, because breast cancers in the younger women tend to be more aggressive. Okay, for women under 40, we do not recommend breast screening with any imaging modality. This is because the incidence of breast cancer is very low in this group. Okay, what do we do with women above 70? There is evidence that there are benefits also in this group when we do screening mammography, but I think it should be individualized. That means we take into account the benefits of mammography versus the comorbid conditions of the women and their expected life expectancy. And if we do decide to screen these group of women, screening should be done at 2-yearly interval. Other imaging techniques, you may hear about breast CT, SINT mammography, PET, other techniques like thermal imaging, optical imaging, electrical impedance imaging. These are all experimental techniques, and I think of these modality, only breast CT holds promise. The underlying premise for screening with mammogram is that it allows for detection of cancers before they become palpable. Okay, and we all know that detection of early stage disease confers better prognosis and better outcome when treated. Okay, to date, there has been at least 8 randomized controlled trials on population-based mammography. There is some variation in the outcome with regard to mortality reduction, but on the balance, we are looking at about 24% reduction in mortality in the group that is screened compared to the group that is not screened. So all the other modalities, they are experimental techniques. This does not show any survival benefit, but we advocate monthly BSE because it is felt that if women examine their breast every month, it would increase their own awareness of their own breast and also breast cancer awareness. Okay, and clinical breast examination, again, it is shown to confer no mortality benefit, but we are recommending that if women do find a mass in their breast, they should consult a doctor for clinical breast examination. The other new recommendation in the revised guidelines is this list of conditions that we should look for hereditary breast cancer syndrome, and these patients who have breast cancer diagnosed when they are less than 40 years of age, those with personal history of breast cancer and ovarian cancer, those with breast cancer and a close male blood relative with breast cancer, and a host of other conditions which I think you can refer to in your guide. We are recommending that if you do come across women like this, they should be referred to tertiary centers for risk assessment and consideration for genetic testing. Okay, lastly, breast screening with MRI. Women who are at high genetic risk for breast cancer will benefit from annual screening, mammography, and MRI. MRI has been shown to be more sensitive in picking up cancers in this group of women who are at high risk. We have to do mammography still because MRI cannot detect the microcalcifications that we would see on mammography. Okay, but breast MRI should not be used for routine breast screening in women who are at normal risk. I'd like to acknowledge my subgroup members. They have put in a lot of efforts to review the literature and to come up with these guidelines. Thank you.